Hi, my name is Tom Fujita from Bali International Hospital in Indonesia. So I'm very honored to have been given this opportunity. Thank you very much. Today I'm talking about the 3D wiring. So 3D wiring enables operator to control the guide wire tip in 3 dimensions. That is overcome to the limitation of angioplasty. So the two key technologies. One is the angio-based wiring. Next is the IBUS-based wiring. First, I'd like to talk about angio-based. The dual multiple angiographic views to estimate the direction usable with IBUS. But although the number of different methods have been proposed, some that confuse you, okay? Today, I would like to present a simple and straightforward approach of this real-time 3D wiring. Recognizes guide wire and tip position in the next view, operator friendly and avoidance of useful wire rotation, no need of bidirectional method. So this is a real time. The method was originally advocated by Dr. Okamura. Shaft to lumen relationships rule. When rotated opposite side, okay. This is a true lumen, this shaft. Then rotate here, RL to LL. It means that rotate to the opposite side. Then shaft is here, behind, okay. And when the view is rotated to the same side as the shaft appears in front of the true lumen. That's simple rule. By applying this simple rule repeatedly, the 3D relationship can be quickly understood, enabling efficient and precise advancement of the guide wire towards the true lumen. Okay, you see the guide wire is located here. Then RL to LL movement, it means the opposite side. So wire is behind, like that, okay, behind. This is LL. If the RL, the wire is right-sided, so move the same side. It means the shaft is front here, okay? You understand easily. With this simple rule, the relationship between the true lumen and the shaft can be easily understood in the next view. Same side is guide wire front, okay? The only rule is the same with front, opposite behind. Same side, guide wire in front of true lumen. Opposite side, guide wire behind true lumen. Repeat rule, guide wire approach true lumen efficiently. So the only rule is same front and opposite behind. More simple. So Okamura sensei mentioned the shaft and divided the shaft and tips, but I understand the only rule, more simple. Tip direction always toward target. It means we have only two patterns. Front shaft, tip behind, or behind shaft, tip front. Okay, you understand? This is a only true rule because the tip always points towards the true lumen. Or with this method, I will show you some cases. Okay, target here, then shaft right-sided. Then move the same side, shaft is same side, RL to LL. So front shaft is front. Then we are the shafted front. Then move the counterclockwise. Okay, like that, counterclockwise. Then not get true lumen. Then move the RL. RL means the opposite side shaft. Shaft is behind. Okay. Then move the counterclockwise like that, but cannot get true lumen. Next, the RL to LL, it is the opposite side. It means the shaft is behind. Then clockwise. Okay, like that. Then get true lumen. Okay, easily. I will show you some animation. This is RL to LL, the guide wire front, okay, like the front, then counterclockwise. Then advance, like that, okay. Then LL to RL, the wire is opposite side. So it means the behind, wire is behind. Okay, behind, okay. Then advance. The wire, the next is RL to LL, it is the front. Same as front, shaft is front. Then clockwise. Then get true lumen. Okay, this is a 3D wiring. Compared with the conventional approach, the use of 3D wiring raises the success rate to approximately 85%. I will show you some cases. Diagonal branch is very difficult negotiated polymer jacket wire. Okay. Because it's some bend, it's difficult to negotiate the wire. So Schönbrach and Gradius cannot cross. We change the 3D wiring using the Conquest Pro 12. Okay, you see here is a distal lumen here. Then shaft is a downward, shaft upper side. Okay, you see? Now is a areocranial. Wire is down upper side. Then move the chip. Okay, same front. Okay, same front. Same front. It means the wire is a front side. Wire in front of the true lumen. Then chip is the right side, left side. Then easy to understand. Clockwise rotation. Okay, now we see from look here 3 o'clock. Then advance wire. Okay, okay, get true lumen. Okay. So next is I will show you the IBUS guided, so-called the tip detection method. The breakthrough is that we can now see in real time which way the guide wire is facing using a repeated back and forth movement of the transducer like that, proximal to distal, back and forth repeatedly. We can understand tip detection. So this is a animation tip detection method. Forward, then tip, back, and shaft. Okay, you can see we can repeatedly. We understand repeatedly. Okay, shaft, and chips. So shaft and chips. This is a tip detection method. So here's a question for you. From this IBUS image, how would you then turn guide wire? Undetermined. However, with tip detection, we see that we can turn guide wire further clockwise. Okay, you see? Shaft chip here, then tip clockwise rotation. The two inventions that made TDA possible are the tip detection method in IBUS and the development of chips, Conquest Pro ST. Until now, in old school, guide wire was performed intervascularly as imaged, and then IBUS was used to confirm the result. Now, with tip detection method, the direction of the guide wire can be manipulated in real time. It was common knowledge that guide wire puncture was impossible for Folsand toward the true lumen. But now, concrete sharpened tips has made it possible. This is system for TDADR. IBUS is always available in Boston, and micro, if possible, is preferred for Corsair as it is associated with HDR. The guide wire used for puncture is Conquest ST is suitable. But if you don't have the Conquest or Conquest with 8x20 or Hornet 14, is suitable. I will show you a case of TDR. This patient was suffered from the broad anterior myocardial infarction with a cardiogenic shock and with a RCA-CTO. So fix the LED and the impeller. The RCA was CTO with ambient proximal cap. So after fixing the LED under the impeller, we tried the RCA-CTO performed the base technique using a 2.5 mm balloon to safely enter into the CTO body. Then followed by knuckling wire as a preparation for TDADR. We delivered the microcatheter and IBUS. IBUS is a Boston IBUS. Opticals. You can see shaft, chip. We should control the counterclockwise. Shaft chips, counterclockwise. Then you see shaft, chip inside true lumen. Okay, you see shaft, chip. Okay. Then we get true lumen. Next step, wire chap, then counterclockwise, then get to ribbon. Then you see this is a shaft, then black out. Okay, black out here. It means that comes a corsair here. Then swap. Okay, comes microcatheter. Then swap. Sion black. Wire easily to close this two lumen like using a Stingray. The final angio. ECMO and impeller were successfully removed after 2 days later. So key message, enhancing success in anterior CTO PCI. Understanding 3D wiring improves safety and raises anterior success rate. Angio-based 3D wiring and TP detection method are essential techniques. Both should be regarded as core skill to master. Thank you for your attention.